So pneumoconiosis, they are defined as lung diseases produced by organic as well as inorganic particulates in chemical fumes and vapors. So it was originally used for non-neoplastic lung reaction to inhalation of mineral dust. So pathogenesis, only a small percentage of exposed people develop pneumoconiosis, and it indicates a genetic predisposition. So the development of pneumoconiosis depends on the amount of particles inhaled. It depends on the concentration of the dust in the air and the duration of exposure, all that. And next, size of the particles involved. So large size means they can deposit as coal macules or nodules or silicosis, etc. Whereas smaller particles, they go into the lung and they can produce acute lung injury. Okay, and also it depends on the size of the particle, the shape of the particle, the solubility of the particle, and also reactivity. Okay, so again, moving on to coal workers pneumoconiosis, it is the parenchymal lung disease caused by inhalation of carbon particles. So basically there are two types of coals, anthracite and bituminous. So A, B, C. Remember, bituminous is associated with cancer, whereas anthracite, it increases coal worker pneumoconiosis risk. Okay, so what are the stages? First, what happens is 1 to 5 microns, it enters the lung and it is eaten up by the macrophages, which get activated after eating the coal. So they secrete cytokines, which causes non-necrotizing granuloma and severe cases fibrosis. Okay, what happens is this is the pathogenesis of coal workers pneumoconiosis. Contaminating silica can also contribute. So what happens is morphology, there is black lung. So okay, there is black lung and you can see coal macules or coal nodules. Okay, M and C, macules, nodules of coal. Okay, macules means 2 mm, okay, in diameter. Nodules means less than 2 cm in diameter. Okay, macule is non-palpable, nodule is palpable. Okay, 2 mm macule, 2 cm nodule. Next, grossly. So actually you can have it in 3 stages, but macule and nodule, you see it in simple CWP with little or no pulmonary dysfunction and complicated CWP, whereas in pulmonary asymptomatic anthracosis, you don't see any gross appearance. But basically the macrophages, they ingest your coal, right? The carbon particles. So the alveolar interstitial macrophages, they have inhaled carbon pigment. Whereas in simple coal worker pneumoconiosis, there is small network of collagen surrounding them. There is granuloma. Whereas in progressive complicated CWP, there is dense collagenous scar with pigment. So that is what is seen here. So pulmonary asymptomatic anthracosis, you only see carbon pigment engulfed by the macrophages, which accumulates in the connective tissue. And simple CWP, you see coal macule, coal nodule, again, both mostly in the upper lobe and upper zones of the lower lobes. Okay, they may produce centrilobular emphysema. In microscopy, you can see many carbon-laden macrophages, and also you can see coal nodules with surrounding collagen and reticulin fibers. Next, complicated CWP, you can see dark multiple black scars, and okay, entire scarring, and also it shows carbon pigment, dense collagen, and disruption of the lung architecture. CWP is usually associated with minimal loss of lung function. Moving on to silicosis, it is a parenchymal lung disease associated with inhalation of crystalline silicon dioxide or silica. Okay, so basically you have two types of silicosis. So basically crystalline and amorphous. So crystalline, the crystals are sharper, so it causes more injury and more fibrinogen. The most common is quartz. But if silica is mixed with coal or iron or clay, it is less sharp and less fibrinogenic. Okay, so susceptible individuals are sandblasters and glass factory workers, stone cutters, etc. So basically what happens is there are forms of crystalline and amorphous forms. Again, quartz is more thing. Inhalation of all the crystalline forms, quartz is most common cause of silicosis. What happens is it is ingested by the alveolar macrophages. Then the macrophages get activated. They release mediators which stimulate fibroblast proliferation and collagen formation. So morphology. Chronic silicosis occurs in two forms, simple and progressive massive fibrosis. So simple. So basically in simple silicosis, you can see pale to black nodules and the hilar nodes are enlarged. Okay, there is eggshell calcification of the hilar nodes. Remember that. So there are tiny, barely palpable, discrete pale to black, and if coal dust is also present, silicotic nodules. And again, hilar lymph nodes may be enlarged, and on radiographical examination, you can see eggshell calcification. So eggshell calcification, you can see there is a thin rim of calcification. And then this is the gross appearance. And progressive massive fibrosis, basically what happens is as the disease progresses, there is expansion and coalescence of the lesions, and they may produce progressive massive fibrosis. So in a background of silicosis, if you have lesions greater than 2 centimeters in diameter of fibrotic foci, then that is progressive massive fibrosis. So they can coalesce to form large lesions, and the lesions are hard because of fibrosis. They undergo central softening and cavitation. Next, microscopy, you can see a silicotic nodule. So basically in the center you have a silica crystal. Okay, then there are concentric layers of hyalinized acellular collagen surrounding it, and finally in the periphery you can see lymphocytes. Okay, chronic inflammation, right? Lymphocytes, macrophages, and fibroblasts. Okay, so polarized light microscopy measure birefringent silica particles in the center of the silicotic nodule. So here you can see in the center amorphous center, and then silica crystals, and hold appearance of concentrically arranged collagen fibers and chronic inflammatory debris. Next, clinical course. In simple nodular silicosis, the lung functions are either normal or only moderately affected. Chest radiographs, they show fine nodularity, and then patients they develop shortness of breath if there is progressive massive fibrosis, and these patients have increased susceptibility to lung infections such as tuberculosis, atypical mycobacteria, and fungi. Asbestosis is defined as an interstitial fibrosis of the lung caused by exposure to asbestos dust. Okay, it does not include asbestos-induced pleural diseases and carcinoma lung, etc. Okay, so asbestos use and exposure. Asbestos is a family of hydrated crystalline hydrated silicates that form fibers. Okay, they have unique physical chemical properties that make them effective for insulation. So they're used in fireproofing, in heat and sound insulations, etc. Okay, asbestos type, you have two types, serpentine and amphibole. Okay, remember this. Serpentine is also called chrysolite. Any name of asbestos other than that is amphibole. Okay, chrysolite, serpentine, the fibers are wavy and curvy and they're malleable. So greater than 90% of industry uses chrysolite. They're curly, right? So they can curl up in the sputum and they're coughed out. And also they're soluble, so they can go into the blood. So they're less pathogenic. Whereas amphibole, they're not malleable. They're straight fibers. So they're rarely used, but they're sharp. They go into the lung alveoli, and in the interstitium and pleura, they cause fibrotic lesions. Asbestosis, remember one thing, it causes fibrotic lesions, especially in the interstitium. Okay. So that is it with serpentine and amphibole form. And next, pathogenesis. So inhaled asbestos fibers reach the air spaces. Macrophages attempt to ingest and clear the fibers. Then there is macrophage activation. They release chemotactic factors and fibrogenic mediators. Both amphibole and serpentine forms are fibrinogenic. The initial injury occurs at bifurcations of the small airways and ducts where the asbestos fibers land and they penetrate. So the end result is generalized interstitial pulmonary inflammation, interstitial inflammation, and interstitial fibrosis. And also these asbestos fibers, they cause reactive free radicals to be generated, and they are oncogenic. At the same time, if you smoke along with asbestos exposure, what happens is there is 55 times increased risk of lung cancer, because asbestos fibers, on top of them, these toxins from the smoke, they get absorbed. This increases the lung carcinoma risk. So gross. Remember, in asbestosis, there is as is at the lower end of your body, right? So remember, at the lower end, the subdiaphragmatic, at the diaphragmatic end of the pleura, subdiaphragmatic, and also at the anterior and posterolateral end of the parietal pleura, there is diffuse fibrosis. There are pleural plaques, pearly white plaques in later stages, but there is diffuse fibrosis. It affects the lower lobes in the subpleural region. Okay. Then microscopy, you can see asbestos bodies. Okay, basically asbestos crystal centrally, and on top of that you have iron deposition, especially it is thicker at the edges, that gives you a dumbbell or fusiform appearance, and they are golden brown in color. Okay, and fibrosis, there is diffuse interstitial fibrosis, there is visceral fibrosis of the pleura, and there is honeycomb fibrosis, and the air spaces are enlarged. So basically the lesions, they begin in the lower lobes and the subpleura. Early lesions, they begin as interstitial fibrosis around the smaller ducts, so alveolar ducts and bronchioles, and it is termed as mineral dust induced small airway disease. Later stages, the interstitial fibrosis becomes more extensive, and it may involve the entire lung. It destroys the normal architecture of the lung, and there are dilated air spaces surrounded by thick fibrous walls that gives the honeycomb fibrosis appearance. Microscopy, you can see asbestos bodies. It consists of a translucent center of asbestos fibers coated with iron, okay, throughout. And the asbestos bodies appear as golden brown fusiform or beaded rods, and the coating is thickest at the ends of the fibers, giving it a dumbbell appearance. And they form when macrophages attempt to phagocytose asbestos fibers. The iron is derived from phagocyte ferritin. And there are also ferruginous bodies. So the other inorganic particulates, not asbestos, may also become coated with iron protein complexes called as ferruginous bodies. And there is fibrosis of the lung, honeycomb fibrosis or diffuse pulmonary interstitial fibrosis with multiple asbestos bodies. So complications are pulmonary hypertension and carpulmonal. Pleural plaques are the most common manifestation of asbestos exposure. They are pearly white, well circumscribed plaques, and usually bilateral, and they involve the pleura over the domes of the diaphragm, and also the anterolateral and anterior and posterolateral aspects of the parietal pleura. And microscopically, you see hyalinized fibrous tissue, acellular, With many slit-like spaces, it shows a basket weave pattern. Okay, they do not show any asbestos bodies and they do not progress to mesotheliomas. Whereas workers exposed to asbestos may develop lung carcinoma and mesothelioma. So concomitant cigarette smoking markedly increases the risk of lung carcinoma but not of mesothelioma. So clinical features of asbestosis. Okay, asbestosis. Initially there is dyspnea on exertion, but later even at rest. Usually it is accompanied by productive cough. There are irregular linear densities because the fibers are straight. And as the disease progresses, there may be a honeycomb pattern. It can progress to cor pulmonale and you can see pleural plaques. Some important points. Kaplan syndrome is pneumoconiosis along with rheumatoid arthritis. Bagasosis is lung disease caused by sugarcane, and bisonosis is caused by organic dust, and it is associated with hypersensitive pneumonitis. Carcinoma lung, so it is the most common cause of cancer death. It was mostly caused by cigarette smoke. In the past, bronchogenic carcinoma term was used for primary lung cancer to indicate origin from the bronchi, but now 5% of primary lung cancers do not arise from the bronchus, hence the term lung cancer is used. So it mostly occurs after 50 years of age, 50 to 80 years of age, more common in males because of smoking. And tobacco smoking, the major carcinogens are polycyclic aromatic hydrocarbons such as benzopyrene, etc., and benzanthracene, etc., and radioactive elements are also present such as arsenic, nickel, cadmium, etc. So you have carcinogens as cigarette tar, polycyclic aromatic hydrocarbons, benzopyrenes, nitrosamines, etc. And also you have phenol, which promotes the tumor. Next, there is strong statistical, epidemiological, and clinical evidence that tobacco smoking is the most important cancer, the cause of cancer of lung. So the strongest association is with squamous cell and small cell carcinoma. Smoking, squamous and small cell carcinoma. So statistical evidence, the risk increases with number of cigarettes smoked and it is proportional to the duration of smoking. And also pipe and cigar smokers have lower incidence than cigarette smokers. Next, cigarette smoking is not only associated with lung cancer but also with mouth, pharynx, larynx, esophagus, pancreas, cervix, kidney, urinary bladder cancers, etc. And clinical evidence, there's a positive relation between intensity of exposure to cigarette smoke and the histological changes in the respiratory epithelium. So basal cell hyperplasia is there, then metaplasia, squamous metaplasia, then dysplasia, then carcinoma in situ. And also few animals develop bronchoalveolar carcinomas after exposure to tobacco smoke. So industrial hazards, again you have ionizing radiation, Hiroshima and Nagasaki atomic bomb blasts, and those people have lung cancer, and also radon. So people working in mines, so they have lung cancer. And uranium, it is weakly radioactive. Asbestos, you keep inhaling asbestos, it develops after a latent period of 10 to 30 years, the cancer, and other carcinogens also. And again, others are atmospheric pollution, it is higher in urban areas. And again, diet vitamin A deficiency, it leads to squamous metaplasia. And also hereditary factors, and first degree relatives have a higher chance of getting cancer, and idiopathic pulmonary fibrosis as with asbestosis. And also genetic predispositions, so CYP1A1 genetic polymorphisms, it metabolizes procarcinogens present in cigarette smoke. Next, again, clinical subgroups, you have small cell lung carcinomas which are highly metastatic and they have high response to chemotherapy, and you have non-small cell lung carcinomas. And molecular genetics, they develop as a multi-step process by accumulation of oncogenic driver mutations. So exposure to various carcinogens produce sequential genetic alterations and epigenetic changes. So squamous cell carcinoma, you need to remember there is loss of 3, 9, 17p. 3 3s are 9 and 9 2s are 18, so 17p. Okay, so 3p loss is there, 9p, so it has CDK and 2A, so there is loss of that, and 17p obviously has p53 also. Again, loss of retinoma tumor suppressor is found in 15% of squamous cell carcinomas. Okay, these are the squamous cell carcinoma mutations. So activation of oncogenes, again lung cancer, so lung fibrosis, so FGFR1 and also MET amplifications. And there is mutation in the epidermal growth factor. Tyrosine kinase domains mutations, you have EGFR and ERB2. And non-tyrosine kinase, you have KRAS mutations. Translocations, again you have ALK. Neuroendocrine tumors, they're associated with smoking, again loss of RB, 3p deletions, TP53, 3, 9, 17p, okay. Next, again, amplification of MYC is seen in neuroendocrine tumors or small cell carcinoma. Microscopy, small cell, okay, MYC amplification. Next, adenocarcinoma, so there is activation of oncogenes, so there are gain of function mutations in tyrosine kinases, so EGFR, ERB2, BRAF, HER2, ALK, etc. So ALK receptor alterations, you can see ML4. Adenocarcinoma, glands like they're secreting fluid, so ML of fluid, so EML4, it fuses with ALK gene, so that is one mutation. And also non-tyrosine kinase, you have KRAS gene mutations. Moving on to classification, so basically in lung cancer, we know that the it is called bronchogenic cancer because most of them, they come from the bronchi. So 75% arise from first, second and third order bronchi, and also they're common around the hilum. So and peripherally, if they arise, they're usually adenocarcinomas. Okay. Next, squamous cell carcinomas, the pre-neoplastic lesions. So first what happens is you have basal cell hyperplasia, then you have squamous metaplasia, dysplasia, carcinoma in situ, and finally invasive carcinoma. So those are the precursor lesions in a sequential change. Next, morphology of squamous cell carcinoma. Obviously, squamous cell carcinoma, it comes from there is hilar growth. Okay, hilar masses are seen. So it is gray, white in color, and it is firm to hard in consistency because of keratinization. It is firm and hard. So cut section shows focal areas of hemorrhage or necrosis. Okay, that is common. Now the pattern of growth, basically, it can be peribronchial growth. Okay, so there could be around the bronchi, and then there could be intraparenchymal growth from the bronchi. It can go into the parenchyma, okay, the interstitium of the lung, okay, or there could be intrusive growth or intraluminal growth. So it can obstruct the lumen also. Microscopically, again, obviously you see keratinization. You can see epithelial keratin pearls if it is well differentiated. Okay, you can see onion skin layers of concentric layers of squamous cells with keratin, or you can see individual cell keratinization as in moderately differentiated tumors. And again, the cells appear eosinophilic, glassy, and there is dense cytoplasm. And also poorly differentiated, you cannot see any keratinization. There are no foci of keratinization, but you can see intercellular bridges because there are slender gaps between the adjacent cells. Okay. Next, moving on to adenocarcinoma, we need to remember that adenocarcinoma, see, it is bronchoalveolar. Okay, so it appears in the periphery. Okay, whereas the other ones, they're usually hilar. Adenocarcinoma gland-like alveolar, so it occurs in the periphery. There are small peripheral irregular masses. Okay, it was once known as bronchoalveolar carcinoma. So now gross appearance, so it occurs in the terminal bronchoalveolar regions, and it is seen at the peripheral portions of the lung as a single nodule, coin lesion. Next, microscopy, it shows a bronchoalveolar growth pattern with no evidence of stromal, vascular or pleural invasion. This is an important point. There is no evidence of vessels are all at the hilum, right? So there is no vascular or pleural invasion. Characteristically, they show lepidic because there is no invasion. The pure bronchoalveolar growth, it appears like a butterfly on a fringe. So there is lepidic pattern, and they grow along the pre-existing alveolar walls without any destruction of the alveolar architecture. They grow on the fence, okay, the alveolar walls, without destroying it. So subtypes are non-mucinous. So you have columnar or cuboidal cells. Mucinous, you have tall columnar cells with apical mucin, intraalveolar mucin. And again, you have mixed appearance also, both mucinous and non-mucinous type. Minimally invasive, you need to remember one thing, it shows lepidic growth, but again, minimal invasion, it does not adversely affect the prognosis. So based on 5 mm invasion, you say whether it is minimally invasive or more than that. So depth of invasion is less than 5 mm in minimally invasive adenocarcinoma. There is no pleural, lymphoid or vascular invasion or necrosis. But at the site of the tumor, because of minimal invasion, there may be pleural fibrosis. Next, invasive adenocarcinoma, it is an invasive malignant epithelial tumor in which there is glandular differentiation and mucin production. It is most common type of carcinoma in women and non-smokers. So again, morphology, it is peripherally located irregular masses because of mucin. They are gelatinous to the touch, they are grayish white. In microscopy, you can see various patterns, a lepidic pattern, and then SNR pattern, you can see regular glands lined by cuboidal or columnar cells to secrete the mucin, and then papillary adenocarcinomas, you have a fibrovascular core, single cell layer, and then micropapillary carcinomas, there is no fibrovascular core. Solid adenocarcinomas with mucus formation, they are poorly differentiated, and also mucus adenocarcinomas, they consist of tall columnar cells with apical cytoplasmic mucin. Okay, they spread erogeneously and form satellite tumors. So again, they have majority of tumors, they are TTF1 positive, thyroid transcription factor 1 positive. They grow more slowly than squamous cell carcinomas but metastasize widely and earlier, okay, because they are peripheral. Small cell carcinoma of the lung, it is previously known as oat cell carcinoma. So it is highly malignant epithelial tumor with neuroendocrine features. See, neuroendocrine features of the lung, the cancers include highly aggressive, low-grade carcinoids, highly aggressive small cell carcinoma, and large cell endocrine carcinoma. So it is strongly associated with cigarette smoking. Male to female ratio 2:1. So site, there are central masses, okay? It arises not only in the major bronchi centrally but also in the peripheral portion. So cut section, it is very invasive, right? So high hemorrhage and necrosis, okay? And the masses are soft, friable and white. Characteristics of tumor cells, they are also called oat cells, okay? Remember SSSSS, small cells, okay, less than 3 times the diameter of a small lymphocyte. So they're also called oat cells, okay. S for scanty cytoplasm, so the cytoplasm is scanty. And S for again salt and pepper chromatin, so there is nuclear molding and salt and pepper chromatin. And another S is for smudging or crush artifact because the cells are fragile. And another S is for they're present in sheets or clusters of cells, the growth pattern, okay. Remember A also, azoparty effect. It is common and so the blood vessel may stain blue due to deposition of DNA from the necrotic tumor cells. It is azoparty effect. So azoparty effect, scant cytoplasm, small oat cells, and salt and pepper chromatin. And again, nucleolus is absent or inconspicuous and high mitotic count. Electron microscopy, you can see membrane-bound neurosecretory granules. So the origin of tumor is from the neuroendocrine progenitor cells in the bronchial epithelium. Evidence is the presence of neurosecretory granules in electron microscopy, and they secrete hormones such as PTH-related peptide, and also expression of neuroendocrine markers such as another SS for synaptophysin and CD57 and chromogranin. They express these. So small cell carcinoma is one of the most common lung cancers associated with ectopic hormone production and paraneoplastic syndromes. They also show high positivity of anti-apoptotic protein BCL2 and behavior. They are high grade, they widely metastasize, incurable by surgery, but they are sensitive to chemotherapy. Large cell carcinoma, it is an undifferentiated malignant epithelial tumor of the lung. Remember that there is no specific growth pattern, but it arises more frequently like this well-defined border spherical in the periphery of the lung. So it is large cell, right? So large, bulging, fleshy, homogeneous. And microscopically, everything is large. So large cells with large or moderate cytoplasm, large nuclei, large or prominent nucleoli, and vesicular chromatin, not peripheral clumping. Okay, and tumor cells do not have the characteristics of small cell glandular or squamous cell carcinomas. Some large cell carcinomas are called large neuroendocrine carcinomas. They grow like carcinoid tumors, and you use IHC markers for differentiation. They show organoid pattern, trabecular growth, peripheral palisading, etc. Combined carcinomas, they constitute 10% of all lung carcinomas. Microscopically, they have combined histology of 2 or more of the above histological types, SCC or adenocarcinoma or small cell and squamous cell carcinoma. Moving on to carcinoid tumors, they are low-grade malignant epithelial neoplasms that arise from the resident neuroendocrine cells from the bronchial epithelium. Okay, so that is why mostly they are centrally located, bronchial epithelium. Age and gender, mostly below 40 years of age. So morphology, they are CCC, okay. Central carcinoids, usually they have collar button lesions. So like this, you can see collar button lesions. Otherwise, they can be obstructing polypoid lesions. So usually they are finger-like or spherical polyploid masses in the mainstem bronchi covered by intact mucosa. Or otherwise, they have collar button lesions when they penetrate the bronchial wall into the peribronchial tissue. Peripheral tumors are solid and nodular. So microscopy, it shows many growth patterns. So you have organoid, you have trabecular or reticular, you have palisading, you have ribbon-shaped and rosette-like arrangement of cells separated by delicate fibrovascular stroma. Okay, again you have moderate cytoplasm, eosinophilic cytoplasm, and small uniform regular cells with fine granular chromatin. So again, you have typical and atypical carcinoids. See, you can remember it like this: pleomorphism, mitotic figures, and metastasis. So PMM. So typical carcinoids, they have less than 2 mitosis per 10 high power fields, and they don't have any necrosis. There is no pleomorphism. Atypical carcinoids, there is more pleomorphism, more likely to metastasize. There are abundant mitotic figures, so increase 2 to 10 mitosis per 10 high power fields. And electron microscopy, it shows dense core granules. It contains IHC, serotonin, neuron specific enzymes, NSC, bombesin, calcitonin, etc. So clinical features, they are discovered incidentally, and if a patient is symptomatic, symptoms are due to intraluminal growth. So there's within the bronchi, if it is there, you cough it out, persistent cough, hemoptysis, secondary infections, bronchiectasis, emphysema because of obstruction, etc. So metastases, majority neither metastasize nor have secretory activity, but in 10% of cases they produce classic carcinoid syndrome characterized by diarrhea because of serotonin, flushing, and cyanosis. Now, secondary changes due to the tumor, they occur in the lung distal to the point of bronchial involvement. So there is obstruction of the lumen of a major bronchus. So partial obstruction half causes emphysema, so half emphysema, and also total obstruction, it leads to atelectasis, and again bronchiectasis, severe suppurative lesion, and there is suppuration, and also compression of the superior vena cava. It results in superior vena cava syndrome. There is a classic cyanosis, so marked dilation of the head, neck and arms, and cyanosis there. So local spread, there is extension to the spread, there is local spread to the pleural surface, pleural cavity, or this side you have pericardium here, pericarditis associated with effusions. Tumor at the apex of the lung may invade the neural structures around the trachea and the cervical sympathetic plexus. It can compress the cervical sympathetic plexus, and it can cause pain in the distribution of the ulnar nerve on the same side and Horner syndrome, so ptosis, meiosis, enophthalmos, anhidrosis, and loss of ciliospinal reflex. So such tumors are also called Pancoast tumors. Lymphatic spread, it can spread to the tracheal node, it can spread to bronchial nodes, hilar nodes, and mediastinal nodes. It can also spread to scalene nodes and clavicular region, supraclavicular vircha node. It may call attention to the primary. And hematogenous spread, mostly 50% go, more than 50% they go to the adrenals, then liver, brain and bone. Staging, TNM staging is done. Clinical course, it is insidious in onset, gradual, and again, major symptoms, they include cough, weight loss, chest pain and dyspnea. So investigations, you do radiological examination, and cytological examination, you do FNAC or bronchoscopy biopsy and bronchial washings, etc. Prognosis, it is poor. Adenocarcinoma and squamous cell carcinomas, they are localized, but the rest two, small and large cell, they are undifferentiated and they have a worse prognosis. So paraneoplastic syndromes, lung cancer may occasionally be associated with paraneoplastic syndromes. So usually ACTH and ADH are produced by small cell carcinomas, whereas hypercalcemia is observed by squamous cell carcinomas. Calcemia. Okay, that's it. So moving on to the examples. So first, ADH, hyponatremia. ACTH, Cushing syndrome. Then you can have hyper or hypocalcemia based on PTH related peptide or calcitonin. Then you can have gynecomastia if elaboration is there of gonadotropins, and serotonin you can have carcinoid syndrome with diarrhea in the GIT, etc. Other systemic manifestations, you can have Lambert-Eaton myasthenic syndrome. It is characterized by autoantibodies against the neuronal calcium channel. There is hence muscle weakness. Then peripheral neuropathy, purely sensory, and dermatological abnormalities, you can have acanthosis nigricans. Hematologically, you can have leukemoid reactions, and hypertrophic pulmonary osteoarthropathy. It is associated with clumping of the fingers. Hypertrophic pulmonary osteoarthropathy. Next, metastatic tumors. So the lung is the most common site of metastasis. Both carcinomas and sarcomas from any site may spread to the lungs via the blood or lymphatics or direct invasion. So local spread into the lungs occurs in carcinoma esophagus, carcinomas, and mediastinal lymphomas. So morphology, there are multiple nodules. There is cannonball metastasis. When large nodules are seen in the lungs, multiple nodules are distributed through all the lobes. They're discrete nodules. Okay, they're more at the periphery. Next, other patterns, you can have solitary nodules also, you can have endobronchial pleural nodules also, any mixture also. And sources of metastasis to the lung, commonly you have carcinoma of the GIT, breast, thyroid, kidney, pancreas and liver, and other tumors you can have osteogenic sarcoma, neuroblastoma, Wilms tumor, etc.